You are listening to the
World Extreme Medicine.
The World Extreme Medicine
podcast.
In this episode, we'll be speaking around crew resource management and non-technical skills with Jan Becker. So what I want to do in the conversation is really examine some of the principles of non-technical skill training required for both medicine and aviation. We're going to explore the concepts of shared situation awareness, closed-loop communication, leadership, and fellowship. We're also going to look at some of the elements of critical decision-making under pressure and how to avoid some of the manifestations of amygdala hijack, and we're going to dig into that as well and much more. So to do this, I have Jan Becker with me. Jan is a CEO. She's a helicopter pilot, a midwife, an international leader, and a Griffith University master's graduate who has carved a unique business path, combining a passion for flying and her skills as a midwife. So as the CEO of the largest helicopter training, pilot training academy in the Southern Hemisphere, Jan coordinates emergency responses in floods, bushfires, and other emergencies, and oversees training of the next generation of pilots. So alongside that, she helps bring new life into the world and has a midwifery training clinic she founded in Tanzania. Jan, welcome to the podcast.
Hey, good to be here.
That's an amazing bio, Jan. It's truly diverse, and it must keep you busy. I guess my first question would be around, could you just speak to your background because it is a unique mix of experience?
Yeah, sure. My father was a crop dusting pilot, and when we were little, we went to Singapore. And in Singapore, I think there was just so much opportunity of meeting different cultures, different people, different food, and you didn't notice the differences. You were just part of it. When I started, I always thought I'd be a pilot, but that opportunity kind of wasn't there in my day, if you like. So I went with a second passion, which was medicine. And, you know, it's funny, I fell in love with a pilot, or I fell in love with a guy who was going to be a deep sea diver, and he hung around my dad so much. He's like, I think I want to be a pilot. And so years later, after we were working in New Guinea, Mike was a pilot and I worked as a nurse midwife there. And I did so much flying with Mike that one day when we started our own helicopter training company, you can't own helicopters and not fly them. And I love the similarities, medicine and flying. If you follow a set of rules, if you don't follow a set of rules, then people get hurt and you hurt others. And I kind of like that. And I like the structure. So it kind of suits me. I'd be a hopeless magazine editor. I couldn't stand the chaos, So yeah, that's
absolutely. And to be honest, Jan, like you said, it's if you're around it all day, why not? I at the moment I'm also in aviation and would love to fly at one point. And I think it's definitely both a unique skill mix, but something which is going to bring me into my next question really, with there is similarities, I think, within both decision making, but this broader concept of non-technical skills. So these softer skills, which I think you maybe carve out as a midwife or indeed within medicine, but then there is a lot of overlay into aviation. Could you maybe speak to the concept of non-technical skills from your perspective?
Yeah, definitely. I mean, let's look at medicine. Let's look at flying. When you fly a helicopter, your hands on, your hands, feet, everything's working. But also within that, you have a certain vernacular that you use. You communicate briefly, concisely, and to the point. It's not a Sunday lunch. It's the same in medicine. We have the checklists, the procedures, but at the end of the day, you can be technically brilliant in a resus. And if you're a useless communicator, you've got to marshal the resources of the team. And in many ways, it can't be a talk fest or a vote system. And a bit like management, it's not a popularity contest, but it's about leading so that you can empower the outcome rather than overpower the situation. And that's kind of the way that I see it. We've all worked with jerks. They're technically brilliant, but they're about as good a communicator as a brick, and they don't create team dynamics. They don't bring out the best. And while things are smooth, and you're having a normal flight in the helicopter, or things are going smooth when you're delivering a baby, it's the holy shit moment that you want those non-technical skills to really shine.
I think that's absolutely true, and also to your point around just the bleed across from checklists, and indeed making sure that the some of the bases are covered through just offsetting some of the making sure that there's compliance there, but offsetting some of the cognitive skills to checklists so that you don't have to remember, you're not reliant on memory.
Yep.
But to your point around also being consistent irrespective of the, and this is this bleeds through to midwifery and medicine and aviation, is you're right, changing circumstances actually when you want to be consistent, concise, have very pointed communication in a calm way is when, like you said, when things are not going well, and that can happen immediately in midwifery and immediately in aviation. Things can change super quick. Could you maybe speak to that?
I think one of the most, I look at it from, I'm a young helicopter pilot. I don't have, Mike, my husband, he's got 18,000 hours. And so his clinical skills and his situational awareness and his ability to cope in an emergency is, far exceeds my own. Yet when I'm standing in a labor ward in Tanzania, and there's 50 to 100 deliveries a day, and there's postpartum hemorrhage and resus and all sorts of problems, I find that my skill there and my experience there helps. The classic for me is when I learned to do auto rotations, was when they turn the engine off and you learn how to land the helicopter. I thought I was going to die. I mean, I couldn't think of anything except don't screw this up at the bottom, And it's so funny because the instructor said to me, look, you need to get over the fact that you're crashing. Once you've accepted that you're crashing, just get that stress out of your mind and just make the best job that you walk away. We don't have to save the helicopter. We just want to save you and the passengers. And it's a little bit, that kind of freed me of that stress. However, if they threw another emergency on me and another, I just didn't have the skill set to take that next step. I take that analogy when I step in a labor ward in Tanzania, and we teach bedside hands-on training for neonatal research in emergencies, because the only way they're going to learn to overcome that tunnel vision or that zoning out where the mind just loses its ability to think is by vicariously learning and seeing how calm it can be. And I look at the emergencies that we do in the helicopter, and I look at the emergency we do in medicine, and it's the same principle applies. You're trying to save a life. It's different to say an emergency in the kitchen where you burnt the soup. Nobody's going to die. So
No,
from
totally.
that, so that's the way I look at it.
Yeah, totally. And actually, you've got super interesting background and reach, because you're not only in aviation and medicine, you also span into a lot of humanitarian work. Like you said, there's the
Yeah.
midwifery training, there's clinics in Tanzania and elsewhere. Could you speak to that? Because I very much, having done a couple of years within ICRC and a couple of missions myself abroad, it's the push-pull nature of humanitarian work is that there is crises, sometimes in the middle of crises, but that non-technical kind of calm, cool, collected decision making and communication is very much required in that domain as well. And it's probably similar in a developing country when you've got clinics, you've got lots of pregnant females, you've got maybe a cadre of students, and
Yeah.
multiple things are happening at once. You've got to be across all these things. Could you maybe speak to your experience of how the bleed over of non-technical skills within humanitarian care?
Yeah, I think the most I think if you're not empathetic and you don't have compassion, don't go. We honestly don't want you. Your technical skills are great, and somebody can put an IV better than I can. But if you can't empower and pass the torch and give people the confidence to deal with a situation that builds the foundation to deal with the next situation, I think you're lost. It's so different humanitarian work because you're often dealing with limited resources, both in staffing and in equipment. And there's no great big red button on the wall that you push when there's an emergency, with 400 people that come to help. And in some ways, there's a quiescence to that, because whoever's there, if you've got a postpartum hemorrhage with a woman that's bleeding to death, you have to be predictive in the way that you deal with things. It's like aviation. We used to talk about, let's be proactive. Well, let's be beyond proactive. Let's be predictive. If we're going to fight fires and we know that we're dealing with smoke and heat and all these kind of things, be predictive on fatigue and water and the wind and where you're going to put the water sources. It's the same in a labor ward. And so you've got to be predictive also in how the people are going to react. And if you can give them the confidence, and if you stay calm when everything is falling apart, I think that they learn vicariously good habits and good checklists. And if you give, one of the things we've really learned, and I took this from aviation, in Tanzania we speak Kiswahili. So you want a word in English that can easily be translated into Kiswahili. So you have key words in a neonatal resus, or key words in a shoulder dystocia or eclampsia. And I think fundamentally those checklists and keywords and your quiescence, if you like, gives them the confidence. Now you could be thinking, holy shit, in your mind, that's fine. You look at Sully, as he's about to land that plane in the Hudson, he looks across his first officer and goes, any ideas? And I just think, what great leadership. He's got 1,000 things going through his head, but he still thought to do that crew resource management, if you've got any ideas. And so to me, in humanitarian medicine, you have got to really foster confidence and develop that foundation. And if you can't, you shouldn't go. You should stay where there's 1,000 people that'll come when you push the red button, and you can be the hero that way,
Yeah. Listen, it's so true. It's so true. Like you said, I think it really is that bedside manner, but also, being, and I'm privy to this, both in principal care, but also within the humanitarian sector is, you're maybe sleep deprived. There's multiple things going on, but it's about retaining the ability to be nice as well as be competent. So it's that blend of competence, but also just, you're there to confer a little bit ease suffering in what is otherwise a very difficult situation for people. And actually that mandates being a pleasant person to be around, and actually and then being a team player. And that kind of brings me, Jan, on to the next question, which is around the sense of shared situation awareness and sort of sharing the mental model, because I think again this probably bleeds quite nicely across maternity, humanitarian, and aviation, where you kind of let people into your thoughts, plan A, plan B, plan C, especially if you're leading, but not even if you're leading, you reliant on other people to share their mental model with you around if someone else is leading. Could you maybe speak to that as a central concept, just that almost spans across these domains?
Yeah, I think one of the most important things is a lot of people they don't have the privilege of seeing themselves from the video lens, if you like. And I think, simulated training and videoing training, and then getting people to actually go back and then have a critique. It's like, wow, is that how I came across? I thought I was like super nice, but I was actually too aggressive, or I was too quiet. I needed to show more confidence. And, we talk about that in aviation all the time. We practice. The simulator rides, your check rides. Every time you go out with an instructor, you're doing emergency training. It might be jam pedals. It might be, auto rotations. That builds that confidence, but it builds layers of ability. And I think one of the most important things that we can do is understand how we are in that dynamic. And when as in aviation, you have the flying pilot and the non-flying pilot. If you've got two pilots in the cockpit, sometimes I've got another person in the back that gives them a hand. Similar in a humanitarian setting, you have the ability to, and to your point, being nice takes a lot more energy than being a silent asshole, I can tell you. You know, it's so easy to be sullen. And as you say, you're not just sleep deprived. You probably spent half the night on the loo, the food's not great, it's hot, it's all that kind of thing. But to me, the way I look at it is you're in their place now, particularly in humanitarian medicine, and they do that 365 days of the year. In aviation, I think being able to see how you are in a simulator and film it and go back to it and practice repetition, and it just brings out and hones your skill. We should never be afraid of the check rides, never be afraid of the checklist, never be afraid of being assessed, because it's an opportunity to learn and grow, even if you sucked at it.
Yeah, no, listen, that's powerful, because I think, like you said, it's feedback. It's you should crave feedback from all angles, because the way to continued improvement and continual iteration over time is by seeking feedback, as uncomfortable as it is. So another point which I've really tried to develop myself over the past few years is around active listening, and running 3 different types of podcasts, but also within aviation, and then also within within pre-hospital care. I'm really trying to get better at truly listening to people, and listening from the word go, because one of the most important things, I think, get you to speak to this actually, a name is so important, but and we blurt them out. I blurt them out. I blurt my own name out just really quickly, but it's picking up on one of the most fundamentally important pieces of communication, which is a name, retaining that name, and then being able to use it later in the communication. Because if I can't hang my communication on a specific name to a specific person, A, it doesn't show them the fundamental respect, but B, it doesn't show them that I'm really listening to them. So I'm really trying to get better at listening to names, so that you can direct your communication. You can start to initiate closed loop communication, whereby with a name, right, yes, Jan, I hear you. I'm going to do X, Y, and Z, and I'll come back to you once that's done. And it personalizes this communication, and that comes immediately over aviation, medicine, and humanitarian. Could I get you to speak to that?
Well, it's funny you say that, because in Tanzania, there's all the Swahili names and the Swahili words, and we have a lot of nicknames for each other, because some of the names I just can't pronounce, and it's become, and they have nicknames for me, what they call me there as well. And it's a very, as you say, it is a powerful, once you create a team, or what I call collective efficacy, we talk about self-efficacy. So we're okay with ourselves and our skills and our mastery, but you've got to be able to get a collective together. And I think names, like you say, is really important. Or even naming a team. If you can't smash out the 25, Kiswahili names, you could probably smash out the name of the team that you're working with that day. One of the things that we found, though, to that, we did a lot of teaching in the classroom on simulated models and blah, 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 and everybody get 100%. Didi, you did great. Okeno, you did great. You walk into the labor ward, and all that went out of the window, and they went back to what their law of primacy was, which was, suction in that case. And so we started a hands-on training at the bedside that was individual. And I found that became so powerful, because we would work together shoulder to shoulder. And I think you get that intimacy. And again, I took that from aviation. We have that intimacy in the cockpit when you work with an instructor and they're teaching you to fly and everything is turning, sideways. There's that element of trust that you're vicariously going to learn from them. You're going to get a bit of their confidence. And so the listening, as you talk about, that active listening, I think in the confines of a cockpit or an emergency, in my case, labor ward, I think it's just so important that you find that, I don't know, I'm going to call it a brotherhood or a sisterhood, that commonality of, you don't have to like them, but you have to respect the position that you're in those situations. So respect doesn't have to always be a likable thing. Some people think you have to like your boss. I don't think you have to. I think you have to respect the position. And in medicine, they're clinical skills, and in aviation, they're technical skills. But yeah, that active listening, it's a lot easier in a cockpit, isn't it? Yeah, you know,
Yeah, absolutely.
and in a way.
Absolutely. And really something else I'd like you to get your steer on and your thoughts on really is around bandwidth. And really all that I guess bandwidth really means is that short-term attention, an ability to attend to what's happening. And to your point around the technical skills, and this can bleed through from aviation to medicine, is when you say I have control, you have control, and there's this handover, but that actually this delegated awareness, because like I said, when you're intubating a patient, there's really all your attention, all your cognitive horsepower is going into that laryngoscopy, and you've almost got to verbalize it. Say, right, I'm going in, I'm now doing laryngoscopy. Please, Jan, could you drive the situation forward, or could you drive anything else that needs to happen forward? And actually recognizing that your own bandwidth is going to be maxed out by a task, and it might be the same flying a plane. You're landing, or you're doing something which is cognitively expensive, and then but verbalizing that, and then allowing other people to maybe drive the wider scene or the wider situation, because you know that your active listening, your ability to hear has gone out the window, your peripheral vision has gone, your wider perspective has gone, and understanding that finite capacity when you're in the weeds, when you're in the technical skills, I think shows me that there's some kind of reflective practitioner element to someone when they know they're going to be expensed through that skill.
Definitely. I mean, taking over, you have control. You've got to hand that. I mean, you might say handing over, taking over, be able to close it. You have control, particularly in a helicopter. Completely different in a plane, because they're sort of dynamically stable. A helicopter's dynamically unstable the whole time. No, I think you're absolutely correct. I mean, in aviation, certainly, in a helicopter, takeoff, transitioning for the hover into forward flight, and transitioning from forward flight into the hover, landing and taking off in an aircraft or a helicopter is your workload is very high. We're lucky in the helicopter. We can just turn the people off in the back, turn the intercom off. Pilots generally give a little announcement saying, we'll be coming in to land, blah, blah, blah. But they usually do it just as before they're going to descend, because they're going to be so busy. I think it's so important, clinically and even flying, is that, like you've said, when you're in an emergency and you're trying to manage things, particularly in a humanitarian setting, you're not just, or for us, we're not just managing what's happening with that particular woman in labor. You're managing the other beds that you can see and what's going on, and just directing them. That's just situational awareness, and experience gives you a much broader, or you've just got more capacity. I've got that capacity as a midwife. I don't have that as a helicopter pilot. The minute they start slamming more and more emergencies on me and making systems fail, it gets to a point where I'm just barely flying the aircraft and thinking, well, I just hope I get this little Hummer on the ground, let alone in one piece. Whereas, it's and it's a good analogy, when you see pilots firefighting, they've got a long line, they're picking up water, they're working on 3 different radios, they've got other helicopters in the area, there's smoke, they're hot, they're hungry, they're fighting the fire, yet they manage that. But if you put a young pilot in that situation, he'd kill himself, because they don't have, or she would, because they don't have the ability or the bandwidth to deal with that. So I think people need to rest easy. You can't run an ER in your first year out as a doctor. You've got to build that foundation and build that confidence and learn. You can learn so much from even non-super emergencies. You learn some of those basic skills. If somebody says put in an IV and you're hopeless, hey, put it in. If it's not an emergency, you got time. So to me, it's about finding that, be kind to yourself. And as senior clinicians or senior pilots, you need to be kind and remember what it was like when you were first learning to hover, or you were first learning to intubate or suture. So, non-technical skills, or that ability to communicate and be empathetic, but empower, I think, is more powerful than anything.
Jan, could I get you to speak to the amygdala hijack? I guess in a way, just your own physiology just taking over, your respiratory rate, your heart rate, your heart in your mouth. Could I get you to speak to just how you either control it or at least acknowledge it?
Well, I think acknowledging that it can happen, I think, is fun. I mean, the first time I was involved in the neonatal resus as a student midwife, I honestly thought I was going to pass out. I just I couldn't imagine a more stressful situation. And then fast forward years later, when I'm doing auto rotations in the helicopter, and the instructor, said to me, "Get over it, it's crashing." And the next thing was, "You better get this right, otherwise we don't need a funeral because you'll be buried 6 foot under." I mean, it was just like that reality. But to me, I think if you acknowledge that that can happen, you can find ways through it. I play specific music on the way to the hospital in a humanitarian setting on the way to the labor ward in the morning, so that when I walk into that labor ward, I am on. And it's specific music, it's empowering music. And what it does is it clears the mechanism for me. It gets rid of all the nerves, it settles things down. Running the code in your head. Flying wise, you can go and sit in a simulator, you can practice those emergencies, but also you can dry fly. So you can run through your head, you've got the weather, you've done your planning, you've set up the GPS, you give your radio call. What if they give a different radio call? So it's that understanding that there will be moments when it's so overwhelming, but if you just take a breath, you can find your way through it. It was so powerful to me. I saw the power of teaching people to overcome that, teaching neonatal resus in Tanzania, when we decided to move it from the classroom to the bedside in an actual emergency. Because I thought, the only way to get over it is to get over it. And I said to them, I won't leave you. I'll be there completely with you. I would let them do as much as they possibly could. I'd talk them through it. And midwives would say to me, "I was so afraid, Sister Gianni. I'm so afraid. I just want to run. When you say neonatal resus, I want to run." And now I step forward. And I think it's so empowering. But, again, you've got to be kind to yourself. You're not going to learn that. I mean, some people just have a tremendous ability to deal with it. And I really admire that. Others, it takes time. We need to be kind to that. But you've got to train yourself. You've got to find mechanisms to get over it. And you've got to be on in the emergency.
So, Jan, just looking at fellowship before leadership, something you said there and is really interesting around, like you said, the first time you're in a neonatal resus, it's overwhelming of sorts. And you also said, that's not the first time you should lead a situation. In fact, you're very reactive in that situation and you're kind of learning and listening along the way. Could I get you to speak to, and it's probably the same as a helicopter pilot, you're just taking in everything as a sponge, and that's the first, second, third, or fourth time is not the time to be leading; it's the time to be learning along the way. So this principle of fellowship before leadership, could I get you to speak to that?
Yeah, I think a lot of people, the rhetoric or what they think in their head is, I want to be the leader. I want to run the code. I'm ready for the code. My boss never gives me a chance. And I think we need to be, again, kind to ourselves and understand it's not just a clinical skill or a technical skill in flying. It is the ability to take in what else is happening around you as well, and to be able to think clearly with clarity without tunnel vision. Often you see, I remember teaching I was teaching a nurse she was doing a dressing. She had absolutely no idea that the patient had completely passed out. She was so intent on doing the dressing. Same in helicopters. You might be so intent, you have an engine failure, lower collective, you look outside, you pick a spot, and that's what you're going to. And you forget to give the radio call, or you don't turn into wind, or you just think, I got to find a place to land. So it's it's that roundedness, or it's that ability to say, you know, there are other elements here that we can make it better. Again, I say, you don't have to like the person that is leading the code, or you don't have to like the person that you're flying with. You might have completely different social standards or cultural considerations, but in that moment, there is a captain. And in a code, there is usually somebody running it. And you have to respect that. Now, if they're a good leader, they'll say, any ideas? What can we do next? Jan, could you do that? Can somebody put in the catheter? Could you get onto, air traffic control and see if we can just expedite this landing? So but that respect is built. I don't think it's a given. And some people leave very good jobs because they don't want to be under the leadership of some people. And we need to take a look around every now and then and do upward evaluations. How did I go today? Did I run the code well? What could I have done better? Have the confidence and have the humility to actually ask people that.
No, absolutely, absolutely. And to your point around just not only learning from others and being very much a good team player, but also you're right around asking questions like how, is there anything else? Am I missing anything? And again, that's an appreciation of this finite bandwidth or finite short-term memory and ability, but also to the point where the leader is visible and there's almost a central point that's all the information is passing through, so everyone kind of knows what they're doing and the plan and can come back to the leader. So there's a clear point of contact or of communication, often at the end of the bed if it's a clinical situation. And again, maybe different in aviation if the captain is in the right seat and the first officer or the junior pilot's in the left. But there's a clear appreciation of the focal point of leadership, and you even in your mind, where the leadership's coming from. So there is this sense of you can rest secure in the fact there is the situation is being driven forward. There is this shared sense of awareness and appreciation of what's happening. Jan, you said something really powerful earlier, which I just want to double click on, one which is around watching yourself back in clinical training, watching the feedback, watching the video, which can be painful because it just is it's painful,
particularly if it was a bad hair day.
But could I get you to speak to just that seems to be becoming more the standard of care or more the standard of training? And my question really is around what's next in this space. But I guess I want to double click on that because there seems to be a commonality of filming training. Could I get you to speak to how powerful that is and how that can almost be bleed across domains, the aviation, humanitarian, and medicine?
Yeah, no, definitely. I think training, videoing training. We do a lot of video training in helicopters, and Mike developed training videos because he felt that it was good for people to see things being done. How calm can it be when there is an emergency? Or how fidgety a pilot can be, that they think they're really calm, but they're fidgeting, they create all this tension. Certainly, I remember I went to a training course where they filmed you doing obstetric emergencies. And then, so you were held in the back, you came in, you didn't know what the emergency was. You then had to, rally whoever you were with. It was all filmed. You came back together and had to watch this appalling display of either bad leadership, good leadership, or clinical skills. But it taught me something so powerful that we need to have anchors that we go to regardless. And it's the same in the helicopter and aviation. Aviate, navigate, communicate. There is no point in giving a Mayday call without aviating first. Get the situation under control. And you watch Sully. If you watch, there's fantastic animations of what happened with Sully. He was working his hardest on checklists and procedures to try and get those engines started again. They were working hard and they were communicating second. And it's so powerful learning. And we do the same in Tanzania. We would film would film, we would have a GoPro at the resus bench. There's nothing fancy about it, or at the bedside. And then we would go over it and say, look what we did there. We didn't do that well enough. I just think it's so powerful. We developed a training model for aircrew trainers, and it was like augmented virtual reality. So when you stick your head out of the cockpit or whatever, or out the back, you get the wind in your face. You get when we developed the simulators, we had the fans, so that the reality was there. And it's so powerful. I just think it's exciting. It doesn't, we can't do that so much in humanitarian settings. But if we can nail that at home and get some checklists and some anchors, they will serve us well. I'm such a firm believer in anchors. When you learn auto rotations, if all you do is lower collect, that's the first thing you say. It's 90% of the job. And as you know, airway, breathing, circulation. It's I don't know. I just think training is so important. Embrace it. Just seek out training to learn. How do they sit down? Find what you love about it, and learn. Become a better leader and clinician and pilot by doing that.
Yeah, Jan, I think that's really important from a number of perspectives, and even just listening to you there, we run a lot of search and rescue simulations within the World Extreme Medicine course, and actually it'd be really powerful to actually maybe film those with a GoPro, because to your point around actually, going back into the debrief and having the images, having the video, just to say, look, these illustrate the salient points we're making right now. Look at whether they're, was there in name use, was there eye contact, were you sharing the mental model, was someone scribing, what was the comms, was anyone delegated to comms? If so, was a closed loop feedback, were you using phonetic alphabet? All these subtle nuances that you can trace and track just from a GoPro, I think is super helpful, actually.
Yeah.
Yeah.
Yeah, it's true. I was just going to say, I did a course at Stanford. It was their simulator for neonatal resuscitation. And again, you walk into the room and, you're being filmed and critiqued behind this screen. But I love, they always put distraction in there. They'd have a mother screaming in the background, or that, and it was, what are you going to focus on? And, the baby's dying. Are you going to, sure, the mother's upset, etc., but she's going to be more upset if you don't save the baby. And I just think there's such great analogies when you show videos of absolute chaos. It brings it to the fore. Yeah, I just think it's so powerful, both for humor, which relaxes people, and they realize, you can make a dick of yourself, but you can still learn. People are afraid to look stupid. Again, if you're afraid of looking stupid, then don't go into humanitarian medicine, because but yeah, I think it's so powerful.
No, absolutely. Jan, as we're coming to land on the conversation, could I just get you to speak to some salient take-home points from the conversation, and just maybe top of mind tips around non-technical skills from your thoughts?
Yeah, no, thanks. I think, I think one of the most important things is to create empowerment with other people, not overpower them. If you think you're clinically brilliant, or you're brilliant at something, then take that brilliance and shine it on somebody else. Put the light on other people. Let them develop their skills. I just think we forget sometimes our journey. There was a time when I couldn't hover, and I couldn't nail hovering, and then you nail hovering, and then you can't understand, well, how come they not hover? I mean, or learning to navigate. And, I don't know if anybody's been on the wrong line, but I've certainly been on the wrong line. And I've convinced myself that I'm on the right place. And it's the same clinically. How many times have we blown an IV? And you're like, how hard can it be? So to me, I think the take home point, for non-technical skills is empowerment and communicate. Find a way that you can communicate with somebody else's hot button. And, the silent, strong type doesn't always work in these settings. We want that confidence, but we want that confidence to be passed on. My instructor once said to me, one of the greatest things about a Bell 47, which is one of the first helicopters we had, which is a helicopter like out of MASH, big blades, nice engine, a lot of inertia in the rotor system. And he said, you could take an emergency with a student just about to the edge and then pull it back, because the helicopter had your back in some ways by its inertia. And I think as leaders, we need to be like that. We need to allow people to develop that skill, get them to a point where they've got enough confidence to go forward, because that's what leadership's about, is passing the torch.
Listen, that's powerful. That's powerful. Jan, thank you for the past 45 minutes. It's been fantastic just to touch base with you and get your thoughts and just get your insights. So thank you.
Hey, you're welcome.
Thanks for listening to the episode. Please feel free to rate, review, and subscribe on whichever platform you're listening to. Please also head over to the World Extreme Medicine website, where you can find more engaging content on extreme medicine webinars and indeed the collection of courses from our global network, including humanitarian, disaster relief, expedition, space, military, tactical, and performance medicine. Thanks again.